For the time saving, I'd like to start this session. This is imaging and the physiology. I'm the Hong from Severance Hospital, and my co-moderator, Japanese famous doctor is Dr. Akasaka. I will introduce the first three sessions, and the remaining two topic will be introduced Dr. Akasaka. Okay, first lecture is the speaker is Dr. Hahn. He title of his topic is Angio-Guided, Imaging-Guided, Physiology-Guided, PCI. Which one, when, and how?
Thank you, Dr. Wang. My topic is Angio Imaging Physiology-Guided PCI. So actually, I'm addicted to IVUS and FFR believers. I think this graph is a role of FFR and IVUS, physiology and imaging. So simple disease, definitely we need FFR to avoid the unnecessary procedure. And complex disease, definitely we need imaging to optimize our stent procedure. So initially, FFR cutoff value is validated against the non-invasive functional test. Look at the above the 0.75, no ischemia, definitely. In addition, additional studies show that the cutoff value located between the 0.75 and 0.880. So phase 1 trial investigators increased the cutoff value up to 0.80. So initially, very initial report to decide the threshold of FFR against the bicycle test and dopamine echo, FFR cutoff value was 0.67 and 0.65. The outcome-derived FFR threshold based on our registry, this MI TVR, including soft endpoint, cutoff value was 0.79, but based on the only very hard endpoint, cardiac death and MI, cutoff value is 0.64. So I do believe that the decision metrics of FFR is very simple. More than 0.80, medication is good. Less than 0.80, standing is justified. Yes, I can more certify the less than 0.80. 0.75, I think the ischemic threshold, 0.70, the threshold for critical stenosis. So I think the beauty of FFR is like this. FFR expressed the coronary atherosclerosis as a highly reproducible number. The 0.80 or significant atherosclerosis, 0.90 negligible atherosclerosis, like this. So based on our large data, show that the FFR more than 0.80, the event rate at 2 or 3 years is only 3.4% of cardiac death MITVR, so very safe. Phase 1 trial, the nicely demonstrated that during the 1-year follow and 5-year follow, demonstrated that at the 5-year follow, p-value is insignificant, but the FFR-guided PCI in multivessel disease reduced unnecessary procedures, so reduced the procedural myocardial infarction and associated with the target vessel revascularization. During the 5 years, use of stent number is reduced by the 30%. Our registry also showed that similar findings. Benefit of FFR-guided PCI is primarily due to reduced number of stents and subsequent decreased risk of pre-procedural MI and repeat intervention. So if we want to do more, when you measure the FFR is more than 0.80, please see the imaging. Yes, this is a preventive trial concept. So only when there is just something wrong in the product, you can put the stent. So when you measure the FFR in very complex scenario, for example, triple vessel disease, I don't think it would be benefit. So this is a phase 3 trial scenario. Phase 3 trial, FFR measurement of those of FFR measurement groups, FFR more than 0.80 is only 24%. In the complex coronary artery disease, triple vessel disease, phase 3 scenario, positive FFR is 80%, negative FFR is only 20%. So phase 3, triple vessel disease only, stent number is 3.7, greater than phase 1 multivessel disease cohort. So at 5-year follow, including the repeat intervention, PCI showed a higher event rate. So very similar to the best trial 5-year event rate. The best trial, we used the intravascular imaging, but not evaluated FFR at all. FAME trial evaluated FFR, but very low instance of IVUS-guided evaluation. So in case of very complex disease, I don't think the FFR would be benefit. So why we need the imaging? So imaging show us that the lesion length, then vessel size, etc., to design, help us to design the stent. So what is a stent? We lens on the stent on the less plaque burden. Plaque burden less around the 50% to predict the instant restenosis. In addition, stent length less than 40 millimeters associated with better outcomes. And what is the stent optimization based on the previous studies, our studies, 5.5 or 5.3, at least 5.0, bigger than 5.0 in non-left main coronary artery disease is associated with better outcomes. So we have to achieve the 5.0 after stent implantation. In addition, so the left main treatment, we can see the many aspects, the optimization criteria and decision criteria. So please remember these numbers, left main, look at the ostium lumen is small, plaque burden larger, and 2 stent optimization, previously 5, 6, 7, 8, now 6, 8, 11. Non-left main, lesion length less than 50, stent length less than 50, plaque burden, lens on the less than 50% plaque burden, lumen achieved the 5, 5, 5, 5. So I'd like to recommend to you that please be an active imaging-guided PCI interventionist. Chasing a goal leads to a better result. Simply watching without action achieved nothing, I think. So what imaging tells us during the PCI? Clinical data. We have lots of clinical data. From the beginning, Antonio Colombo nicely showed that if we look at the IVUS and high pressure, we can reduce the stent thrombosis. In addition, the first, as far as I know, this is the first report that the imaging-guided PCI can reduce the risk of stent thrombosis. In addition, SJ-Bach also started the left main stenting with the IVUS, and many small randomized trials failed to show that the benefit of IVUS in the routine practice. But IVUS XPL, Dr. Hong, as far as I know, first randomized trial to show that benefit of IVUS-guided PCI, the long lesions, ultimate or coma-based, renovate complex PCI, complex cases. Limited 4, unfortunately, didn't show any benefit, but October bifurcation, ACS trial, OCCUPI ACS trial, meta-analysis showed that the benefit of imaging-guided PCI, all meta-analysis, many lesion subset, particularly the complex subset, show that the benefit of imaging-guided PCI. Last year, this year, ACC guideline, imaging-guided PCI recommended 1A indication, particularly in the complex coronary disease. Then CAG is enough for me to do PCI? I don't think so. The coronary angiogram is just above the coin flip. So very inaccurate to determine the lesion significance and predict the stent optimization. So we have another tools, angiogram plus more, I believe that can make a better result. But the QFR, although QFR has a complete result, favor 3 China, favor 3 Europe, even though I think the Angio-FFR is better than Angio-guided PCI. In addition, sometimes we need the QCA, protocolized QCA PCI, or some AI-based the software helps us the better stent optimization than Angio-guided PCI, like the FRESH trial. This is my conclusion. For simple lesion, why we do FFR? To avoid unnecessary PCI. And complex lesion, we have to do the IVUS to optimize the PCI. So we have to decrease the risk of procedural complication and improve the patient clinical outcomes. So CAG only not enough. If you have some AI tools, can make improve the CAG plus AI tools make improve the procedural outcomes rather than Angio-guided PCI. So this is my last slide. Please remember these numbers, 3% at 2 years. Prevent trial, optimal OMT groups 2-year event rate is 3.4. Whatever you do in your daily practice, patient PCI outcome should be lower than 3% at 2 years. I think this is our target. So please use FFR and intracoronary imaging wisely to improve the patient outcome. Thank you for your attention.
Thank you. We will move the next topic. Next speaker is Do-Yoon. His topic is OCTIVUS trial, the OCT-guided versus IVUS-guided PCI in all-comer PCI.
Yeah, thank you, Chairman. I'm Dr. Do-Yoon, and I will talk about the OCT versus IVUS-guided PCI. Now, as Dr. Ahn said, that now the intravascular imaging is recommended as a class 1 in complex lesions, and all the guidelines recommend IVUS or OCT as the same alternatives. And now we have two imaging modalities. One is OCT, and another is IVUS. And OCT is just like a radar. It uses light waves, visual light or electromagnetic waves. So it has the high resolution, and we can visualize very small structures like stent stroke or endothelium. However, it's easily blinded by fog. So we need RBC clearing for the OCT imaging. And IVUS is just like sonar that use sound waves. It has deep penetration, and we can see farther. However, so we can fully visualize the vessel. However, it's unable to discern very fine details. So this is the more detailed difference between two modalities. The actual resolution is higher in OCT, but it needs blood clearance, and the OCT can more well visualize the calcium or lipidic plaque. However, the plaque burden and vessel size and ostium can be visualized only in IVUS. And this is my personal favorite indication for OCT versus IVUS. Instant restenosis or calcified lesions, some culprit detection, OCT can be helpful. But in the left main disease, especially ostial lesion and CTO and renal dysfunction and decompensated heart failure that needs to save the contrast or the fluid amount, and the patient with a poor guide support or dolly flow or flow limiting dissection that cannot visualize the distal vessel, and IVUS is the number one, the priority, the imaging option. And in phantom model and some coronary artery model, OCT versus HD IVUS showed that a little bit bigger the lumen size measuring by IVUS and a little bit smaller lumen size measuring by OCT. And in OCT versus IVUS for guiding PCI, which will offer better clinical outcome, there was some data from the Japanese trial opinion, and we did another trial, OCTIVUS trial, in 2,000 patients in all-comer PCI. The composite primary endpoint defined as target vessel failure, a composite of cardiac death, target vessel MI, or ischemia-driven TVR at 1 year was evaluated between OCT versus IVUS-guided PCI. We included all the patients, just excluding STEMI or severe renal dysfunction without dialysis and cardiogenic shock patient. And 2,008 patients were randomized and followed for 1 year. And the mean age was 65, and diabetes was present in 1/3 of the patient. And the major indication of the PCI was cerebral angina in 2/3 of the patient. And the multivessel disease was in 60 patients, and left main, bifurcation, OSTR, CTO, and calcified ISR, diffuse long lesion were all included in the study. And PCI was majorly performed in radial access, and 97% of patients implanted drug-eluting stent, and mean stent number was 1.6 with a 47 millimeter of the stent length. And the total amount of the contrast media used was higher in OCT-guided PCI. The primary endpoint was comparable between groups, 3.1% in IVUS and 2.5% in OCT group. proved the non-inferiority of the OCT compared to IVUS-guided PCI. I'm happy that the rate is lower than 3% that Dr. Ahn mentioned. And the secondary endpoint, the target lesion failure or death, TVR, other contrast-induced nephropathy was not different between OCT-guided and IVUS-guided PCI. And the pre-specified key subgroup analysis by clinical factors like age, sex, diabetes, and the lesion factors did not show clear benefit in some subgroups. And we did additional subgroup analysis with the complex coronary lesions, including left main bifurcation, ostial lesion, CTO, calcified lesion, and multivessel long lesions in 1,475 patients that also showed comparable clinical outcome in median 2-year clinical follow-up. And the target vessel MI, death, TVR was all comparable between groups, and procedural complication was a little bit lower in OCT-guided PCI and with a little bit lower peri-procedural MI rate in OCT-guided PCI. And another subgroup analysis with the two bifurcation lesions in about 400 patients, including the left main and LA diagonal, the bifurcation. And two-stent technique was done in 42 patients of these two bifurcation lesions. And also in 3-year, primary endpoint was comparable between groups and 10.8% in OCT-guided PCI and 7.4% in IVUS-guided PCI group. Another subgroup analysis with the in-stent restenosis showed a very interesting finding. The OCT-guided PCI group showed the lower clinical event rate at median 2-year follow-up with a hazard ratio 0.34. And the patient with the main difference was driven by the target vessel MI and TVR in long-term follow-up. And another subgroup analysis with the acute coronary syndrome that showed no difference between OCT-guided and IVUS-guided PCI with a 2-year target vessel failure, 9.2% after the image-guided PCI. So in conclusion, in this OCTIVUS trial, we showed that OCT-guided PCI was non-inferior to IVUS-guided PCI with a target vessel failure at 1 year. And subgroup analysis involving patients with complex lesion, bifurcation, in-stent restenosis, or ACS presentation consistently showed comparable clinical outcomes between two modalities. And in small number in ISR patient, OCT showed benefit, the better clinical outcome at 2-year follow-up. So this is my conclusion. Regardless of whether it's OCT or IVUS, the appropriate use of intracoronary imaging based on the lesion characteristics and clinical context or the physician's preference will lead to improved clinical outcome if it is used appropriately. Thank you for your attention.
Okay, thank you. We will move to the next topic. The speaker is Byeong-Keuk Kim, and he will present the OCCUPI trial, the OCT-guided versus the Angio-guided PCI in complex lesion. He's the main PI of the OCCUPI trial.
Thank you, Professor Hong. I am Byeong-Keuk Kim from Yonsei University. So last year, we published the data and reported the outcome at the ESC. OCCUPI study was the multi-center randomized trials. Our study's hypothesis is the superiority of the OCT-guided PCI for complex region over the angiography-guided group. Also, a total of the 1,604 patients was randomized into 2 groups, and complex coronary lesion include this complex region. So when you look at the procedural outcome, is stent diameter is greater and high pressure post-dilation more frequently performed, and maximal inflation pressure was greater. So based on these characteristics, post-procedure MLD was greater in OCT-guided group. So this is the primary endpoint. When you compare the occurrence of the primary endpoint, OCT-guided group showed a significantly low rate of MACE as compared to the angiography guided group. The main reduction of the OCT guidance was driven by the lowering occurrence of the spontaneous MI and TVR without raising the concern of CIN. So in this study, is a stent optimization criteria was suggested. Stent optimization was assessed according to the pre-specified OCT criteria regarding stent expansion, position, and edge dissection. So this is the comparison of between the patient with stent suboptimization and stent optimization. A patient with stent optimization showed a better clinical outcome as compared to the patient with sub-optimization group. So the previously many lecturers already told us that now is ESS guideline is the use of the imaging, especially for the complex reason is 1A evidence, and also the this is the our editorial from the Mamas and Gary Mintz. It's the most important thing is how to use it and whether optimal imaging criteria have been achieved. So if the incidence and predictors, the clinical outcome was assessed in our OCCUPI trial. So from our OCCUPI trial is a patient who underwent OCT-guided PCI with post-stenting OCT evaluation were enrolled and classified into two groups, OCT optimization group and sub-optimization group. So what about the incidence? The stent optimization was achieved approximately 71% undergoing OCT-guided PCI for complex reason. However, nearly 1/3 patients demonstrated the stent optimization despite the OCT guidance. So what's the predictor of the this kind of stent optimizations is definitely is a diffuse long lesion and small vessel diameter were identified as significant independent predictor of the OCT optimization. So this is the clinical outcome of each component among OCCUPI OCT criteria. Each defined component of the optimization criteria, stent expansion, stent opposition, edge dissection was significantly correlated with the primary endpoint at 1 year post-PCI. What about the stent expansion? In our OCCUPI trial is absolute expansion and relative expansion criteria was suggested. The criteria regarding the relative is the MSA greater than 80% of the mean reference lumen area or greater than the distal lumen area. Absolute expansion is 4.5 was suggested, is effectively predicted the risk of the 1 year clinical endpoint. The best cutoff value was 83% for MSA to the mean reference lumen area, and also 100% ratio to the distal reference lumen area, and then the absolute MSA was 4.5, which aligned with the predefined our threshold of the OCCUPI trial. So this is the data of the acute stent malposition. A significant relationship was also observed between the acute stent malposition and clinical outcome. Optimal cutoff value identified is 380. This value is also closely similar with our predefined specified criteria of the 400 micrometer. Luckily, last week this data was published is a European Heart Journal for successful OCT-guided PCI of complex reason, comprehensive evaluation of stent morphology considering the three key components is of the stent optimization, our OCCUPI criteria, along with the maximal effort to achieve stent optimization are essential. So, and also this year, we reported the data of the OCT ACS trial. This study was focused on the subgroup of the patient with ACS. About nearly half patient was ACS in our study. This is the comparison of primary endpoint in ACS subset according to the randomized imaging guidance strategy among ACS patients. As you can see, OCT-guided group showed a significantly low rate of MACE as compared to the angiography-guided group. cardiac death is relatively low in OCT-guided group, and TVR is also low, and myocardial infarction is the total myocardial infarction rate is significantly low in OCT-guided group. So this is the analysis of the post-hoc composite. Is a composite event like cardiac death, MI or stent thrombosis, or death spontaneous MI stent thrombosis TVR rate is significantly lower in OCT-guided group as compared to the Angio-Guided group. And we perform also to compare the optimization rate among ACS patients assigned to OCT guidance. So as everybody can expect, OCT optimization group in ACS is also significantly low rate of MACE. So ladies and gentlemen, this is my take-home message. The first one, OCCUPI trial was the first to clarify, demonstrate the clinical benefit of OCT guidance compared to the conventional angiographic guidance in complex region. From OCT optimization study, meeting the optimization criteria was strongly associated with better clinical outcome. Each predefined component of the OCCUPI optimization criteria, expansion of position edge dissection, was independently and significantly correlated with a one-year clinical outcome. And then the OCCUPI ACS subset analysis demonstrated evident cardiovascular benefit of OCT guidance over angiographic guidance in reducing the risk of the one-year MACE of the ACS patient, and this such benefit was particularly observed in patients who achieved the stent optimization. Thank you for your attention.
Okay, we will have a discussion time for 15 minutes regarding to the three presentation. Any comment? Okay, go ahead.
Okay. Thank you for great talk to all speakers. The great congratulations on the great achievement. One more thing I wanna point out here is the other aspect, like the first thing is that the procedural suitability. Second thing is that compositional information. Any speakers, do you have any comment on that? Maybe I think the Kang, Dr. Kang can be the best to answer this question.
About the plaque composition, you mean? Yeah.
Procedural suitability and composition. IVUS versus OCT.
The OCT and IVUS also the in our trial the use of the DES or the balloon or NC balloon was not different between groups. However, in the image evaluation data, the OCT showed smaller the lumen as the well described the difference between the OCT and IVUS. However, in QCA analysis, there was no big difference between groups. So actually, this is my one concern is that the OCT evaluate a smaller lumen, a bit smaller, and so the operators can select a little bit smaller the device. So I think that can be related to the difference in the peri-procedural myocardial infarction in some patient, but this is not very clear because in the statistical analysis, the difference is not significant in all aspects. But this is what I'm concerning. Yeah.
Yeah, I have a question to the Do-Yoon. I actually love the result of the OCTIVUS trial, especially subgroup analysis of the complex lesion. Yeah. But it's interestingly, data show that the IVUS group have a higher rate of the target vessel MI and the procedure complication compared with the OCT group. But what I remember that is the minimal stent area and the expansion rate is higher than the OCT group. So how can we interpret this kind of the achievement is the optimization is better in the IVUS group, but in the complication rate is higher also in the IVUS group?
Yeah. That's what I am concerning about the difference between the OCT and IVUS. In long term, the long-term TVR death or spontaneous MI was not very different between OCT and IVUS. However, in short term, just after the procedure, periposition MI or the procedural complication like no reflow or some abrupt closure was a bit higher in IVUS group. First, it can, because it's the subgroup analysis, it can be a little bit biased between the two groups. And second, a more aggressiveness with the selecting bigger balloon or bigger stent, higher pressure with the IVUS could affect a little bit higher the periprocedural myocardial infarction in some aspect. But in long term, the clinical outcome was not different between OCT and IVUS. So this is a big question to me. That we believe the bigger is better. Then how big is the best? So that is the concern about after this trial.
Yeah, actually, yes. There are no significant difference by guideline between OCT and IVUS at the moment.
Yes.
But your sub-analysis demonstrate a small difference because each modality may have an advantage and disadvantage. And based on your sub-analysis, you try to focus on some specific trial to realize the difference between OCT and IVUS in the future.
Yeah. And the most interesting target can be the instant restenosis for those patients. Yeah.
Thank you.
I have a question for Professor Jung-Min Ahn. And I know that you could recommend that for left main bifurcation, we use intravascular imaging such as ours to choose the treatment strategy for one stent, two stent for left main bifurcation according to the circumference osseum. And in the main trial, I noticed that the words FFR was angiographic PCI. So I think that in cath lab in our hospital, the intravascular imaging such as was more frequently used in left main bifurcation. So in this trial, do you have some limitation? Do you have some restriction for the use of hours? Because if patients in the angiographic-guided PCI use more intravascular imaging, will have dilute the influence of FFR guidance. And you know that Dickey Crush 6 that in true bifurcation lesion, Dr. Shaoliang Chen provided that FFR was angiographic, didn't have significant clinical outcome, but only reduced the stent number. So I noticed the main trial also used composite ischemia events. And so do you have some protocol for the FFR group? Both the circumflex to left main or LAD to left main is ischemic, you will do PCI, or for the post-optimal result for the 0.9 for this trial? Thank you.
Yeah, thank you very much. First of all, thank you very much for the being interested in our trial. So in our trial, both groups we highly recommended the post PCI, the imaging guided stent optimization. So the comparison is only decision making to treat or not the angiography versus FFR. In addition, post FFR. Post PCI FFR is not, we measured it, but it doesn't change our treatment strategy. In our trial, the imaging guided post stent optimization is more important.
Prevent trial showed that the preventive stenting is superior to the optimal medical therapy in patients with vulvar plaque. Yeah. I remember that the criteria of the vulvar plaque in the prevent trial include the small MLA, large plaque burden, syncytial and high lipid core burden index. I believe that stenting is a better option than the medical therapy in patients with small MLA and large plaque burden. But how many patients have the large MLA and small plaque burden with syncytial or lipid core? Do you think in such a patient, stenting is necessary?
Yeah, and actually the number is very. almost it is very rare because more than 90% of lesions are already small lumen large plaque burden, for less than 4 square millimeters and more than 70% plaque burden. So, so we have to consider the preventive trial. We have to consider the VIVO trial because we have to consider enrollment criteria of preventive trial. Preventive trial, angiographically, more than 50% diameter stenosis and FFR negative. So the already preventive trial lesions, the large plaque and small lumen.
Today also you recommend how to use physiology and imaging, right?
Yeah.
The importance of physiology is defer the patient,
Yeah.
not to treat,
Yeah.
right? But imaging demonstrate the optimize, right?
Yeah.
But the prevent trial, you're focusing on the non-significant FFR group, right? But the imaging demonstrate the vulnerability.
Yeah.
So is it very important, even if the FFR is negative, try to use an imaging to identify the vulnerability? Do you think?
If you want to do more, so if you just leave it alone, I don't recommend the further evaluation. So if you treated some, even though the FFR is negative, so I feel very uncomfortable, leave it alone. Then at least evaluate the imaging. So without any high-risk plaque, then leave it alone is justified. And there is some high-risk plaque, yes, based on the preventive trial, so you can reduce some risk. So preventive trial, give us some gradation. The FFR-guided decision-making is very strict, but in the very strict decision-making metrics, preventive trial give us some gradation.
Yeah, I congratulate the success of prevent trial. You didn't open the Pandora box, right? There are lots of discussion, and yes, but yes, in a case with a high risk factor such as diabetes and smoking, hypertension, or something, in that case, it is important to do the imaging to identify the vulnerability of the plaque, right?
Right.
And there are some observational trial. If we control the smoking and hypertension, the event rate will decrease. It's an observational trial published recently. So we have to focusing on the background.
Yeah.
Is it okay?
Yeah, I also fully agree with your opinion. So background medical therapy risk factor control is very important. But I assume, but even though I assume that similar to the large pimple on the face, large pimple cannot control by the medicine. Sometimes we need a squeezing. So
I think so in the how do we apply the result of the prevent trial in clinical practice? You know, the physiology studies are just later on. Before the publication of the prevent, we do the PCI in that region is not allowed it. But after the publication, we have another option. What I mean, PCI is available, is justified. So we choose just the medical treatment is good. We do a PCI, it is good. Both are good. So we have two options. Select on what is the best one for this patient. It's up to the physician's decision.
So you have to consider that we have to get the very optimized result. Remember, less than 3% at 2 years.
What I mean is that sometimes we do the imaging looks like very vulnerable, looks like some ugly feature. Every physician's worry about what can we do. At that time, physiology study we do that, and the FFR is more than 0.8. The guidelines just touch it, but we have a concern, worry about that. But publication of a prevent trial, we can fix it. The PCI. That is the rationale.
I'm still wondering the direct comparison of the FFR with the imaging-guided intervention looks tricky because the two information is different. FFR for decision for intervention and imaging-guided PCI concept is included more the comprehensive assessment like optimization and the plaque characterization beyond the decision of the stenting. So in your slide, you showed the AI-based Angio FFR, right? Yeah, then I suggest that if we first do your AI-based Angio FFR and then imaging-guided PCI, that is the best strategy for all the region.
So, yes, I think that if the medical cost is cheaper than today, the FFRY is already reimbursed, but the imaging is very expensive. So, the imaging guiding catheter is very cheap, FFR is very cheap. We have to, easily we can use the both modality, but nowadays both devices are a little bit expensive. So, in the later, so more cheaper AI, benefit of AI is very cheap. So if we have another AI tools to support the Angio-Guided PCI, then it would be the good option in the low resource restricted hospital or situation.
Okay, thank you very much. Because of time limitation, we would like to move to the next talk, and we'll discuss later, including a whole presentation. Next speaker is Joo-Yong Hahn, Samsung Medical Center. His talk is entitled Intravascular Imaging in Contemporary PCI, Lesson from Recent Advances. Please.
Thank you, Chairman. Good afternoon, everyone. I'm Joo-Yong Hahn from Samsung Medical Center, Seoul, Korea. These are my disclosures. The most recent ESC and ACC-AHA guideline have upgraded the intercoronary imaging guidance to Class 1 with the level of evidence of A, based on several large clinical randomized trials. So the benefit of intravascular imaging guidance itself is not really questioned anymore. What matters now is how we apply it in place. Today, I would like to focus on three key questions. The first, which lesion truly require intravascular imaging, complex only versus all comers? The second, how should we perform intravascular imaging effectively regarding standardization and criteria for optimization? Lastly, why is IVI still underused? Current hurdles and the potential solutions. The Renovate Complex PCI was the first large randomized trial that demonstrated the benefit of intravascular imaging guided PCI for a complex PCI. This was an investigator-initiated, multi-center, randomized, open-label trial at 20 sites in Korea. Patients with complex coronated lesions undergoing PCI were randomly assigned in a two-tone fashion to undergo either intravascular imaging guided PCI or angiography-guided PCI. At a median follow-up of 2.3 years, the cumulative incidence of target vessel failure was significantly lower with the intravascular imaging guided PCI compared with the angiography guided PCI, 7.7% versus 12.3%. The other landmark trial was Illumine 4. In this trial, the patients were randomly assigned to undergo OCT-guided PCI versus angio-guided PCI. Notably, in this trial, not all patients have high-risk lesions or complex lesions. Although the minimal stent area was significantly larger with OCT-guided PCI than angiography-guided PCI. The clinical outcomes were not significantly different between the two strategies, suggesting that the benefit of intravascular imaging would be more prominent with complex lesions rather than all-comers or simple lesions. What is important or the controversial issue is the definition of complex lesions. In the Renovate complex PCI, the true bifurcation lesion, chronic total lesion, and protected left main lesions, severely calcified lesions, or etc., were classified into the complex PCI. I do not claim these criteria would be gold standard or the optimum criteria. However, in pre-specified subgroup analysis, the benefit of intravascular imaging was the most prominent in the true chronic total occlusion, unprotected left main, diffuse long lesions, and the severely calcified lesions. So I would say we need to perform intravascular imaging-guided PCI at least in these subset of lesions. The second topic is how should we perform intravascular imaging effectively? In the Renovate complex PCI, we adopted the most contemporary criteria of PCI optimization at that time. The stent optimization was defined as a sufficient stent expansion without major dissection or malopposition. The MSA was recommended to be greater than 5.5 square millimeter by IVUS and greater than 4.5 square millimeter by OCT, or the ratio of MSA to average reference lumen to be greater than 80% in non-left main lesions. In post-hoc analysis, clinical outcomes was best in patients with imaging guidance PCI with the stent optimization, followed by imaging-guided PCI without stent optimization, and worst in the angiography-guided PCI group. However, the stent optimization could be achieved only in half of all patients. In the secondary analysis, we investigated prognostic value of intravascular imaging parameters in patients undergoing complex PCI. In our study, the 5.5 square millimeter of MSA was the best cutoff value for prediction of the risk of target lesion failure. And the MSA was the only independent predictor for the risk of a target lesion failure. The other suboptimal findings, such as relative stent under expansion, major malposition, or major dissection, was not significantly associated with the risk of target lesion failure. When we incorporated the MSA and other suboptimal findings, among patients with MSA smaller than 5.5 square millimeter, the outcome was poor, regardless of the presence of other suboptimal findings. However, when we achieved the MSA of 5.5 square millimeter, the absence of other suboptimal findings was associated with excellent outcomes, suggesting that after achieving MSA, probably we should try to fix that suboptimal findings such as malopposition or major dissection. And in our institutional registry data, after the introduction of standardized protocols, the outcomes of intravascular imaging, IVUS, was superior compared with the previous era without standardized protocols. The third question is underuse or current hurdles. One of the biggest hurdle for intravascular imaging would be medical costs. The annual and the total cumulative medical costs were projected along with horizontal lifetime horizon. As you can see here, the total cumulative medical costs were reversed between the two groups due to a higher increase of annual cost in the angiography-guided PCI groups. During a 3-year follow-up, the total cumulative medical cost and the quality were both higher with the intravascular imaging-guided PCI than with the angiography-guided PCI, resulting in ICER of about $57,000. Conversely, in lifetime simulation showed that the total cumulative medical costs were reversed between the two groups, and the quality was consistently higher with intravascular imaging-guided PCI, resulting in a dominant ICER. And the other problem is the operator's inertia or inexperience. In our institutional registry data, the outcome of complex PCI started to improve after 5 years of experience. The experienced operators did complex PCI better than inexperienced operators, naturally. The IVUS was beneficial in both inexperienced operators and experienced operators. However, the benefit of the IVUS seems to be more prominent among less experienced operators, suggesting that the importance of education. This is my last slide. In summary, the benefits of IVI-guided PCI are most pronounced in complex lesions, but this does not imply an absence of benefit in simpler lesions. Achieve adequate stent expansion first, then consider to correct major edge dissection or malposition. IVI is cost-effective and may ultimately be cost-saving when long-term outcomes are considered. IVUS in complex PCI and operator experience are independently associated with lower long-term cardiac death and target vessel MI. The benefit is even greater for less experienced operators. Standardized training and the system-level support may be needed. Thank you for your attention.
Thank you, Dr. Hahn. Let's move on to the next talk. Next talk will be presented by Dr. Bon-Kwon Koo. His talk today is entitled Physiology in PCI, Current Concepts and Clinical Applications. Please.
Thank you, Professor Akasaka and Professor Hong. Good afternoon, ladies and gentlemen. I'm Byeong-Keuk Kim from Seoul National University Hospital, and these are my disclosure. The title of my talk is a little bit different from the others, not about data, not about paper, but about concept and clinical application. I think the concept is enough for the Class 1A indication, and this concept has been expanded and extended to the non-hyperpressure ratio, resistance assessment, physiological lesion distribution, angio and image-based physiology assessment, and finally expanded to the AI-based risk prediction. But for clinical application, I know there are several questions and skeptical thoughts that the physiology is too complicated, and invasive physiology indices and studies are mainly for simple lesion researches, so there is not much clinical applicability in daily practice. So today I'd like to share 3 consecutive cases I encountered one morning session to illustrate the clinical applicability of physiology in daily practice. So first case, 71-year-old gentleman, multiple risk factors, have been under medical treatment for a long time, but asymptomatic, but recently had a symptom, and CT showed that the approximate AD progression, 70%. Personally, the patient had a strong dislike for the stent, as his mother passed away due to stent thrombosis. So when I recommended invasive procedure, the patient refused, but finally agreed to do an invasive procedure after I guarantee that I will do a very careful consideration for stent implantation. So here's an angiogram. Small RCA total occlusion. It was there for more than 10 years. LAD progression, proximal AD, and distal AD. So it may be a straightforward case, but the question is how we can define by yourselves and myself very careful consideration for stent implantation. I adopted these numbers from IRIS registry data, so we use the cutoff 0.8 for the major adverse cardiac events, but when you use the term very consider, I think we have to adopt the criteria for the risk of death or MI. So it is below 0.7. So in this case, when I measure FFR, it was 0.68. So it's a careful consideration stent indication. And when I did a pullback for this case, this LAD is small step up, proximal LAD very big step up 0.23. It is far above the ACS risk criteria of 0.1. So stent implanted by IVUS guidance 3/30 and measure the FFR. The problem is that the post-PCI FFR is 0.79. We know from this IPD meta-analysis that the risk of death MI increased when the post-PCI FFR is below 0.8. So the question is, should we need another stent in terms of very careful consideration for stent implantation? But when I did the pullback, I found that that significantly low FFR was due to the far distal lesion, and delta FFR cross stent is 0.03, below the cut point of 0.05. So I was happy, and I thought that it was a very careful consideration for stent implantation, and now patient also happy. So the second case, relatively young patients, swimming coaches, multiple risk factors, triple vessel disease, underwent PCI for triple vessel disease with 3 drug-eluting stents and 1 DCB, and he admitted due to the recent chest discomfort for CAG. So this was initial angio taken in 21, LAD DES, circumflex DCB, and 2 DESs in RCA, and this is the angiogram taken at this time. So LAD stent looked fine, circumflex DCB looked fine, RCA2 stent looked fine, but you may find that there's some hazy slit-like luminal narrowing at the far distal LAD. My patient said, our fellow said, it looks okay, but I wasn't that happy with that. So it was 5 French diagonal catheter, and I advanced the pressure wire into the catheter and measured the FFR. It was 0.89, pull back, no delta FFR changes at that lesion, so I thought it's fine. So finished the procedure. Another case is more younger patients, 49 asymptomatic patients, also under medical treatment for non-ischemic coronary lesion, LAD 30 to 50%, exercise stress test negative, and under statin and clopidogrel. And the patient was admitted because that the exercise stress test converted to positive, even though the patient was asymptomatic. So here's an angio, LAD, multiple tandem lesion, including diffuse stenosis, and in the right coronary artery, far distal PL branch, it's become a rupture and subtotal occlusion. So both or either can be a cause for the exercise stress test. First RCA was treated by DCB. It doesn't seem to be perfect, but it was small branches, so I thought it's fine. And the question is how we can deal with these 3 lesions in LAD. 1, 2, 3, focal plus diffuse lesions. So measure the FFR, 0.76. So it needs treatment. But the question is how to treat these lesions. When I did a pullback, I found that there is a moderate step up at each segment. So the question is how we predict the post-PCI FFR and how to relieve ischemia in this patient. So for this, I will not go into the detail of this calculation. You have to do a little math, 1 minus 0.05, 0.06 alpha, beta, but it's simple math. It's not that complicated. So my decision was to fix the lesion number 2 and 3, and it will relieve ischemia. So this is post-PCI FFR, post-PCI angiogram, but you see there's a very tight pinchedness in the first diagonal branches, and pressure wire is at the LAD, so it's not that difficult to retrieve that pressure wire and putting into diagonal branches. It was 0.68. So pulling back, you see there is a big step up at the diagonal branches, and push again, and another big step up. So this may be needed. And this is final angio. So I did the kissing balloon angio plot for that segment and additional high pressure balloon inflation for the LAD, and diagonal FFR has become 0.91, and LAD FFR becomes 0.86. So I briefly showed the 3 cases, and applying this rather complicated concept into daily practice may be complicated, but using pressure wire in these cases are not that complex and simple. So use of pressure wire and a little math can make PCI simpler and more straightforward. Thank you very much for your kind attention.
Thank you. So now it's a time for discussion about 15 minutes, right? Any question or comment, especially?
Question, Professor Joo-Yong Hahn. Yep. In your research, is the image guidance show the significantly greater benefit? In your research, is the image guided show the greater benefit, especially for the less experienced operator? But current data lack of the evidence of the benefit for the simple lesion. So I think that the all PCI cases seem to be the complex PCI for the less experienced operator. So my question is how should we train or teach the fellow or instructor during the PCI? For example, okay, so you have to perform the image-guided PCI for every whole cases, or is just follow the guideline, is a complex PCI, we need this image or something like that.
So, thank you for your good question. As I mentioned in my presentation, there remains controversy regarding the criteria of complex lesions, and it depends on the operators. So the complex lesions are, the meaning of complex lesions are different according to operators by operator, and inexperienced and less experienced or experienced. So I do not have any objection for you to do IVUS or OCT in simple lesion or all lesions. But what is important is do intravascular imaging accurately. So by protocol-wise or for achievement of stand optimization, it is more important to the selection of a case.
Yep. Dr. Hahn, yes. You recommend some protocol on the final result, but there are two results, optimal and suboptimal result. Are there any reason they try to get an optimal result, but they failed to get an optimal result? Are there any reason they failed to obtain the optimal result?
Yeah, thank you for a very nice question, Akasaka Sensei. Actually, in my opinion, the success of achievement of stent optimization may be according to the lesion characteristics. So if the lesion is very tough or very calcified or very long, it would be very difficult for us to achieve stent optimization. But when we achieve stent optimization, anyway, the results is good. So I think that we have to try our best to achieve the optimal results.
Dr. Han, I have a question. The currently beneficial of the imaging-guided PCI is based on the angiography criteria in complex region. But when we met the patient, quite simple, the process is not going not simple unintentionally. It means that the complex patients is also beneficial for the intravascular imaging, such as highly inflammatory or thrombotic patients.
Yeah, I think so. But anyway, in data-wise, the benefit of intravascular imaging seems to be more prominent in complex lesion, not the patient complexity. But as I mentioned, I do not have any objection for you to do intravascular imaging in any lesions.
We have to keep in mind in the high risk patient profile, it is not regional characteristics. Dr. Kim said that there is a lot of the good data is the IVUS image-guided PCI in the simple lesion. I don't think so. One of the typical example is Illuminant 4. Illuminant 4 is a negative result. Why? It is a simple lesion. So anyhow, so to the simple lesion imaging for the educational purposes or training purposes is good. But real clinical practice, therefore we do the all imaging in the simple lesion. No. It is not allowed. More question?
I have one question for Professor Kim. I think one optimized criteria is map position, and you see the renovate data, map position is not associated to the long-term mass. But Professor Kim's data show the map position related to early event. Do you think we need other associate factor, maybe the site of map position, like calcium or large vessel, maybe the difference to this outcome?
Okay, thanks for the great question. So when you compare the two clinical trials, the first one is definitely the OCCUPI trial is an OCT study, and also the Renovate trial is 70% maybe the IVUS. So the some measurement of the distance between the vessel wall and stent strut is a quite different one. And second one is we are now performing the assessing the some relationship or association between stent opposition and expansion. So very simply, anyway, the reason with the significant greater acute malposition had a higher instance of the peri-procedural MI. That is very easy understanding. So more bigger balloon needed, or one more step anyway needed. And next one, anyway, the sum two expansion and opposition, right? So we are doing the some secondary analysis. Anyway, our data is independently associated with the clinical outcome.
Regarding to the acute stent malposition, this data clearly show that the presence of the severe acute malposition was an independent predictor. And some clinical registry data also show that. But the other side, in the Japanese data, and even for some simple lesion, acute stent malposition is not associated with a worse outcome. What is the problem? It means that the acute stent malposition is classified two types. What is that? Very severe calcific lesion is inevitably make this acute stent malposition. Stent malposition is very severe. At that time, what is try to fix the acute stent malposition is not treat the acute stent malposition. We have to fix that cases. Usually, stent under expansion is the main cause. So treat the stent under expansion first. But just reading the acute stent malposition is associated with a poor. So other stent all expansion is perfect. There is no edge dissection. Everything is perfect except for acute stent malposition. Only something wrong. At that situation, we try to fix it. No, it is not good. So we have to be two different situations. Everything is good, and the only severe acute stent malposition, just let it alone. And combine the other opposition and the under expansion, severe calcification. At that time, we try to fix that.
Okay. Yes, please, Jeffrey.
Thank you. My question is to Dr. Hahn and maybe to the panel also. So this 5.5 millimeter square minimal area and this absolute value, it means something very different if it's a 3.0 LED versus a 4.5 millimeter RCA. So when do you just stop at the 5.5? And when do you decide to look at the relative expansion, whether it's percentage of the distal or percentage of the mean? So I'd like to know what your thoughts are on that particular aspect. When do you take relative expansion once you've achieved 5.5?
I will present in detail. Actually, the several studies report that what is the criteria for the stent expansion. Some study 5.0, some study 5.5. So, and there is some relative. So actually, we need a validation. Input a large number of patients in the patient level and then verify what is the critical one. And we did. And one of the findings is relative criteria does not work. It does not any statistical significance. Only absolute value working. So if you can try have the capacity, I can achieve 5.5. It's good. And the relative criteria, no, it is not working. It's don't care about the relative criteria.
Thank you. But just to extend that, if you have let's say take an RCA, and you get 5.5 somewhere in the middle, and above it it's 10 millimeters square, below it it's 10 millimeters square, surely that cannot be adequate, right? I mean, just intuitively thinking about it.
You mean in the left main cases, Dr. Hahn suggests the area is 6, 8, 11.
Right.
So in the large vessel should be larger. And what I mean is that the 5.5 is driven from the whole data. So if the vessel size should be larger, anyhow, it should be larger. But at least achieve the 5.5.
Right.
Discussion point is a little bit different. But I think his question is only one cutoff value is enough or not, right? But it depends on the patient population and it might be different in each study. But Dr. Hahn's trial, they decided the ROC cap and best cutoff and 5.5 in your cases, right? And finally, I would like to ask Dr. Koo, right? Today you simplified the physiology in the intervention, but in a case with diffuse disease, right? Sometimes FFR may underestimate each region, or because it looks like lots of tandem region, right? Similar to the lots of tandem region. If the diffuse region and FFR is less than 0.80 or less than 0.7, right? If we put the proximal lesion, the stent, the distal FFR does not improve much, right? How to predict the final FFR? And even in a case with such a diffuse disease, you try to put the stent in the proximal lesion?
Thank you for asking the very important, but it's very complicated question. So for 100%, I cannot be sure, but you may have some insight when you deal with those lesions. But it goes with the previous questions and discussions about how do we achieve optimal PCI in terms of both physiology, imaging, and I personally believe that it's determined in advance. For diffuse lesions, regardless of using IVUS, OCT, FFR, you cannot make a perfect outcome. Suboptimal results always happens even using imaging and physiology. So in that perspective, I think regardless of using imaging, physiology, image-based physiology, or combining together, pre-treatment assessment is very helpful. And now, having said that, now we have Angio-FFR, CT-FFR, which enable us to better predict the outcome before doing the procedure. Once we put a stent, there's no way to return it.
May I ask Dr. Koo? There is two different the result from the Flavor 4 China and the Flavor 3 China and Flavor Europe. How do we interpret the different finding? And actually, this is published in the Lancet. How do we apply it? How do we interpret that finding?
Yes, so that's a very important question. So Faber 3 China, Angio versus QFR. Faber 3 Europe, QFR versus FFR. So it failed to satisfy the non-inferiority. Actually, it was worse, and the outcome was similar at 2 years. So there is a contradictory results. And there's another trial, Flavor 2, which compared the Angio-FFR versus IVUS. It met the predefined non-inferiority margin. But the big difference between Faber 3 Europe and Flavor 2 was that the Faber 3 Europe only used the Angio-FFR for decision-making only. But the Flavor 2 trial used the decision-making and post-PCI optimization. And in our data, we found that the additional procedure after putting a stent, after doing a post-PCI angio-FFR, there's additional procedure in around 20-25%. I think that's a big difference. So that the Faber 3 failed, many reasons for that, and we will have to have 2 big randomized trials coming next year. So then we will finally have whether it will be downgraded or upgraded. But the lesson I learned from this trial is no matter what kind of indices, either imaging and physiology, unless you are doing it properly, it will not improve the outcomes.
Okay. Final comment for the Dr. Colombo and comment and question.
I don't think you can use the stents to treat diffuse disease. Right. Stents were not made for diffuse disease.
Right.
Oh, it's a wrong device.
Right. Thank you very much. The final, good comment. Thank you very much. So it's a time to close this session. Thank you very much for all the attendees and the panelists and all the speakers. Thank you very much.